Call upon Dr. Achyuth Gongada, Senior Consultant and HOD, Department of Anesthesiology, Apollo Hospital, Visakhapatnam, to deliver the next talk.
Persons and the delegates. At the outset, I would like to thank the organizers of ISA South Zone Conference Mysore and ISA AP as well for inviting me to speak on this topic. As a part of the major and critical surgeries, we are going to discuss the spinal reconstruction surgery, which is not very commonly done, but it is challenging for the anesthetist, for the surgeon and the patient as well. So for the next 15 minutes, I'll be speaking through various steps involved in this surgery. So this is the X-rays of pre-op and post-op surgery of a patient with spinal deformity, and everyone can appreciate the nice work done by the surgeons. But unfortunately, the difficulties faced by the anesthetist, the crucial steps managed, how he saves the life of the patient, make him more comfortable, they're less often appreciated by the public or the doctors. So let's go through various concerns that we go through. So it's a major surgery, a prolonged surgery, and lots of fluid shifts, airway difficulties, and surgery is done in prone position. There is a lot of possibility for iatrogenic injuries and also injury to the spinal cord. So we deal with various types of spine problems, that is, can be degenerative, autoimmune, or metastatic spinal cord lesions, or scoliosis, and acquired spinal injuries like trauma-related injuries. So scoliosis is defined as more than 10% deviation in the longitudinal axis of the spine, and it can be either idiopathic, congenital, or neuromuscular disorders. So the congenital scoliosis is usually associated with other congenital other congenital problems we have to look for while we are anesthetizing the patients. And about 10% of the idiopathic scoliosis patients, they require surgical intervention. And Cobb's angle is the measure of the severity of the disease, and it usually corresponds to the other comorbidities associated when we deal with the patient. And pulmonary function tests usually shows restrictive pathology, and a vital capacity of less than 40% would indicate or warrant us to prepare for the post-operative ventilation. So this is the Cobb's angle. More severities, the comorbidities are also going to be severe, and the surgery is going to be difficult. And the degree of the angle that corresponds to the change in the forced vital capacity or the total lung capacities. And there can be primary or secondary cardiac problems, because there can be hypercarbia, prolonged hypercarbia, and secondary pulmonary cor pulmonale, and we have to deal with it. And if it is rheumatoid arthritis, there can be airway problems, cervical spine problems, eyes can become dry and get injured easily, and there can be gastrointestinal or renal problems secondary to NSAID use, and pulmonary interstitial fibrosis is also a problem. So in preoperative assessment, we have to be careful with the detailed history and examination, a special emphasis to the airway, cardiorespiratory, and neurological symptoms. And there will be restricted mouth opening, even glottic opening is restricted, neck movements can be restricted, and atlantoaxial dislocation instability will be there, and if we are not careful enough, we may cause injury to the spinal cord at that level, which can be life-threatening. And the associated neurological deficits, which are pre-existing, should be noted carefully, so that there is no claim that it was caused during the surgery or anesthesia. And if the patient had previous anesthetic records, that would be of a lot of use, both for planning the anesthetic and for and post-op management. So if the patient is planned for intraoperative neuromuscular monitoring, screening of various contraindications, relative or absolute, should be done, which can be loose teeth or metal or electrical devices, implants in the patient's body. And the concomitant cardiorespiratory problems, both the history and the valvular problems would be of use, and the exercise tolerance, chest X-ray, pulmonary function tests, and the blood gases would be of use in quantifying the problems we are going to deal with as far as cardiorespiratory systems are concerned. And communication is very, very important. It's a major surgery, and the patient and family should understand what they're going through, and the coordination between the surgeon, anesthesiologist, and the neurophysiologist, if they are involved, should be there. So patients should have realistic understanding and expectations. They have to understand the problems because of prone surgery and the prolonged surgery, and perioperative visual loss is also a problem and has been reported more than other surgeries. And patient is to be educated with various steps involved in waking up test if we are planning to do one. And also they should be aware of the intraoperative waking, so that they don't feel that it was an unplanned awareness during surgery and the corresponding psychological trauma. So monitoring, along with the minimum standard monitoring required, we usually go for intra-arterial blood pressure monitoring. Also the central line is required both for monitoring and infusions, as the patient can have fragile veins. And if it is long duration surgeries like rheumatoid arthritis, etc. And intraoperative blood pressure intraoperative sampling of bloods would be required for blood counts, thromboelastogram if required, and ABGs. And BIS monitoring, if available, would be of a lot of use, because we take the patient through various planes, lighter and deeper planes of anesthesia, and that would help a lot in these situations. So airway, as I said, it's very difficult, and especially the cervical spine surgeries, there is a lot of increased incidence of airway manipulation, and reintubation rates are high compared to any other major surgeries. And the College of Anaesthetists of Australia and New Zealand, they published nice guidelines in various stages. Preoperative, if the patient has one of the predictors of difficult intubation, rheumatoid arthritis, or significant cervical myelopathy, they suggested awake intubation or fiber optic intubation or video laryngoscopy. And intraoperatively, if the patient has any of the difficulties of difficult extubation, if there are more than 2 of these factors, they suggested delayed intubation in close monitoring in ICU, or extubate on an exchange catheter. And if the patient is agitated or any signs of airway obstruction early in the postoperative period, they gave the list of possibilities, and the anesthetist or intensivist should look for the possible causes and attend early, so that we don't go into catastrophic situations. So this is a nice, I don't know how clear it is, but if there is airway edema, like the risk factors are operating time more than 5 hours, blood loss more than 3 liters, or more than 3 levels of C-spine surgeries, and cervical myelopathy preoperatively, they suggested to delay the extubation. If it is only one risk factor, you can think of extubating the patient immediately after surgery, but if it is more than one risk factor, suggested that you delay the extubation and avoid remanipulation of the airway. So spinal surgery is divided into 3 types, 3 grades based on the expected blood loss, less than 100, 100 to 1000, and more than 1000 ml of bloods. And the scoliosis surgery, there can be 3 approaches, either posterior, which is most commonly done, and then anterior release surgeries, and combination of these 2. And sometimes these 3 steps are combined with rib resections and hemivertebrectomy for optimal surgical results. So we have to deal with all the possible surgical planning. And prone positioning, we have to be careful, and we have to understand that it's going to be difficult because of the patient bodily deformities, and the pressure points are not usual. There can be a different site than your expectations. We should be careful with the endotracheal tube and IV access difficulties. And intra-abdominal pressure should be, intra-abdominal pressure should not be increased, so it should be free from pressure, and IVC compression should not be there, so that the surgical site is not congested and no bleeding, no increased bleeding happens. And as I said, it's a major surgery, long incision, bone resections. So there is a possibility of blood loss, as if it is a complex surgery, there can be more than 1 liter of blood loss. So there should be good assessment, planning, and preoperative supplementation, either nutritional or preoperative blood transfusions. And invasive blood pressure and cardiovascular central venous pressures should be monitored. And also, if cardiac output monitoring is required, if with major blood loss expectations, it can be used. And the intraoperative normovolumic hemodilution and cell salvage techniques and induced hypotension, if experienced enough, you can use them. And tranexamic acid, there are not many guidelines available on usage of tranexamic acid intraoperatively and postoperatively, but it is widely used in spine surgeries, and it has to find a place, tranexamic acid has to find a place in the guidelines. So cell salvage techniques, it has been suggested in by many professional bodies. If there is more than 10% of expected blood loss compared to the total calculated blood volume, it is suggested, and it offers a lot of advantages. But the initial cost and the staff training issues and 24-hour availability would be a problem. But it is suggested that we use it so that we don't have problems with major blood transfusions. And this is how it is done. The blood from the surgical site is collected, it is processed and washed, and then PRBC is prepared and it is given back to the patient. The maximum hematocrit that can be achieved is 55%, and that is useful in reducing the number of external blood transfusions required for the patient. So the spinal cord damage, because the surgeon plays around the spinal cord, there is a lot of possibility for the damage, and the waking up test and intraoperative neuromuscular monitoring would definitely of help in scoliosis surgeries. And the risk factors, there are both patient factors and the surgical factors. If the corpse angle is high, corresponding increase in the risk, and also the surgical approach, the osteotomies that we do, thoracic hyperkyphosis, if it is there, it increases the risk. And the hemodynamic disturbances which affect the spinal cord perfusion pressure would all add to the risk factors to the neurological damage. And when we do the intraoperative neuromuscular monitoring, it aims at decreasing the damage and also increasing the outcomes of the surgery. So when we do wake-up test, we have to explain it beforehand to the patient, the every steps that we do. And then once the surgery is done and when we reach the time of the test, we continue the analgesia part but discontinue the anesthetic part and the muscle relaxant part. And we have to use peripheral nerve stimulator to look the response for the train of 4. And then you wake up the patient, give instructions, and 2 SSS should be there, but at the head end and the foot end, and the patient is assessed. Once that is done, patient is anesthetized back for the surgery and then recovered after the surgery. What are the advantages and disadvantages? The waking up test, it doesn't need any equipment, and the results can be seen physically. And the disadvantages being it's one of the tests and it cannot be repeated, or it won't give you continuous information about the patient. And the sensory system cannot be assessed, only the motor system can be assessed, and sometimes it can be too late before we identify the problem and do some corrective measure. So, and also it cannot be repeated many times. Maximum times we can repeat is probably twice and not more than that. So the alternative is using the electrophysiological method, which involves usage of EEGs, EMGs, and evoked potentials. And it can give continuous recording of the events, and we can early detect the problems early during the course and do some corrective action. Just one more minute. So the sensory tracts are assessed using somatosensory evoked potentials. The wrist, ulnar and radial nerve, or the tibial nerve are stimulated, and the transcranial electrical potentials are recorded. If the amplitude drop is 50%, it warrants problems. And the motor transcortical electrical stimulation is done, and the surgical site electrodes record the amplitudes, and those will be useful in detecting the injuries. So once, if at all there is any abnormal method, we check the result, and then all the anesthetic part is optimized, and the surgeon is warranted so that they have to remove, if they have to remove the rods or stop traction, they would do that and decrease the damage. And post-operative visual loss, again, it could be due to ischemic optic neuropathy or because of the central retinal artery occlusion, and the risk factors are mentioned. And we need to make sure that the risk factors are attended so that vision is not lost. And we have to understand that it's a long surgery, and long surgery carries correspondingly risk factors for the problems, post-operative morbidity, and at every step we have to reduce the duration of surgery. And enhanced recovery would be useful after spine surgery, and we have to plan it preoperatively, intraoperatively, and postoperatively, and patient should be offered the benefit of enhanced recovery in spine surgeries too. Thank you.
Thank you.